I'm Bob Cusack, Editor-in-Chief of The Hill. Thank you for joining us for our program today, Cancer Care Access and Equity, Breaking Barriers to Innovation. And thank you to City of Hope for their support of today's program. We live in a groundbreaking era of innovation in oncology, yet cancer continues to be the second leading cause of death in the United States. According to the American Cancer Society, there will be over 1.9 million new cancer diagnoses this year and over 600,000 deaths. In addition, cancer costs the United States a hefty $208 billion each year. Many patients are not able to access the benefits of cancer innovations, and too many people, particularly those from historically underserved communities, are without the care they need to survive. To combat the impact of cancer, federal health officials recently introduced initiatives such as the Cancer Moonshot Plan, which aims to cut the cancer death rate in half within 25 years. What obstacles stand in the way of optimal cancer care? How can we increase cancer screenings, advance research, modernize detection and treatment systems, and drive innovations while removing barriers to access and affordability? What role do social determinants of health, like geography and race, play in keeping patients from specialized life-saving care? And how do we eliminate these disparities? Well, we have an outstanding group of guests joining us this afternoon. But before we get underway, just a reminder that you can tweet us at The Hill Events using the hashtag #TheHillCancerCare. Joining us now is Representative Mike Kelly of Pennsylvania, co-chair of the Cancer Caucus. He is aiming to increase funding for cancer research. Welcome, Congressman.
Oh, Bob, thank you. Thanks so much for having me. I appreciate this.
So obviously, just want to get to the news of the day, news of the month, and we have the debt ceiling deal. Is this going to jeopardize any cancer funding?
No, I don't see any reason why it would jeopardize that at all. I think, after this drama that we saw a week ago, and to be very candid about this, since I've been here for 12 years, every time I hear somebody say, this is the most important vote you'll ever take in your time here, and I say, you're right, until next week, then there'll be another one. But the most important vote of all is the vote we cast when it comes to fighting cancer, and especially when I look at the most important asset that our country has, because we know that 25% of our population is our youth, but they're 100% of our future. And so if we can't protect our future, there's no sense in being here. These other votes are important, but funding alone is the key to winning this battle against this incredible disease that affects children. And just being the people we are, the most vulnerable are the ones that need the most protection. So I just think that on this, it's always been a natural for me. I've got 4 children. They're all grown now, but I've got 10 grandchildren. And wow. I think there's not a parent out there or a grandma, grandpa, and uncle who just fears the thought of somebody getting that message that your child has cancer, your grandchild has cancer, your granddaughter, your grandson, your niece, your nephew. I mean, it's just so elementary to who it is we are as people. We always want to protect the most vulnerable, and we want to make sure we're doing everything to give them a chance at life. So this one to me is not even debatable. This is the easiest vote anybody will take, and this is one of the best spends of our taxpayer dollars that we can have. So I'm just glad to be part of it. I'm glad to be here at a time when we're looking at legislation that's critical, and again, protecting some of the most vulnerable people in our country.
Well, Congressman, we had your colleague Congressman Higgins on from the caucus, and he was talking about some legislative priorities other than funding government agencies to combat cancer. Are there legislative priorities you think could get done between now and the end of the year, or between now and the next election in 2024?
Listen, and I don't want to be casual about this. You can't outlaw cancer. You can't pass a law that's going to say we're done with it. We're not going to have it anymore. We're just going to uproot it and throw it out. No, you can't do that. But you can do is you can guarantee funding for the people who go to work every day. And I have I marvel at this because most people think of doctors as being this upper echelon and the upper earners when you come to being in our economy. These are people that aren't interested in income. They're interested in outcome. They are so concerned and so focused on this battle against cancer that they go to work every day with only one goal, and that is to stamp this out and do everything they can. Now, we know right now that about 80% of children that have cancer get cured. There's another 20% that are there. That 20% is what we're looking at today and saying, listen, we have to keep going. We've got a great start, but we haven't crossed the finish line yet. We may never cross the finish line, but we'll never stop trying to cross the finish line.
You're a big proponent of telehealth, and I remember when I used to cover Medicare and Medicaid many, many years ago, telehealth was coming on the scene, and it, of course, exploded during the pandemic, and the pandemic was tough on a lot of people. But can you talk about the advantages of telehealth going forward now that the pandemic is over?
I would think that if you were to look at most members of Congress, most of them come from areas that are predominantly rural areas. The big cities are the big cities. That's one thing. But a lot of our population is not in the big city. They're in rural areas. Getting to the type of care they need is difficult. Getting a diagnosis is difficult. But if you can go on a screen and get the answers you need to get at a critical time, that oftentimes will turn the ship around and be able to get these people to a cure and not to something else. And I just think that what we've been able to do when it comes to the ability this country has, in fact, the world, of communicating and getting the message out and getting answers to people and getting help to people. Telehealth is one of the biggest things we've done that really eliminate that idea that I'm 3 hours away, I'm a day away, I have to get in an airplane and take whoever it is that needs this help across the country. The telehealth, we can do some things that we couldn't do before. And it's that early detection that is the key to all of this. And so a lot of this takes place right in our own areas where we can actually talk to people in this line of business and they can help.
Mm-hmm. As you know, Congressman, there are a lot of government agencies that deal with healthcare, whether that's CMS or FDA and NIH. And over the years, we saw during the Trump administration the Right to Try bill, which became law. But still, there's some frustration with whether it's FDA or CMS for coverage issues. What do you think is something that the government agencies really need to get? What you hear from cancer patients across the country, because a lot of them are frustrated that there are some experimental things out there and they don't get access to them.
Yeah, well, I think that's the Right to Try was based on that. I think the other thing, there's nothing more frustrating, and I don't want to say this critically, but I have to. Listen, there are too many hurdles you have to jump over, too many hoops you have to run through that make it almost impossible to get to the answers you need to get and to get the help you need to get and get the type of diagnosis you need to get. As we said earlier, it's that early detection that puts us in the right direction to finding out what is it that we can do to help early on what some of our folks are going through. So, but when I look at all this and you start thinking, there are so many agencies. You look at this alphabet soup when you get into the federal government, and then you can go to the state governments and you get all the whole way down the line. You have to go through agency after agency after agency after agency. And all we're looking for is a yes or a no. Can we help this person? What is it that we have to do to help this person? Can we change the direction that we're going? Why do we have to go through agency after agency after agency, through hearings after hearings after hearings? Some of these things are so simple. If anybody tells me, look, we'll get to your problem once we get clearance from all the agencies, I say, you know what, let's do it differently. Let's get people who were elected, and I love the name, not representative, not congressman, representative. We all represent about 750,000 people. If somebody calls our office and needs help, if I tell them, well, you know what, it's going to be a long time for me to get you an answer because I've got to go through this agency, and this agency, the only thing you get in the other end is that sigh of saying, but Congressman, I can't wait that long. And so it's baffling to me. And listen, there's no other place in the world like this. Mm-hmm. But we need to keep it that way. I don't want to be an also ran. I don't want to be a country that almost got there. I want us to be the leaders across the board in everything we do. We need to be the envy of the world on what it is we do to protect just a precious asset is our youth. And so we have to work on these things, and we have to be more, and it's not a matter of being bipartisan, it's being a little bit intelligent. We need to be able to jump over some of these hurdles ahead of time rather than waiting. Being in a waiting room is nothing more frustrating. And I would just ask anybody that watches, there's nothing more frustrating to go to a waiting room and you have a child or an adult that needs care right away. And you're so far down the list, you say, you know what, I'll come back later. I don't know that we can wait any longer. And by the way, the issue that we were here for is no longer an issue.
Mm-hmm. I have an audience question for you, and this comes from Emma Tramble, CEO and Chief Engagement Officer, Wiser Strategy, Inc. And Emma asks, out-of-pocket insurance deductible costs cause a great deal of medical debt during cancer treatment. What can legislators do about this issue?
Well, but as what Emma's asking, so out-of-pocket insurance deductibles. So the question is, I don't know what kind of a policy you have. In order to get to a premium maybe that you could afford, you have to go with larger deductibles, right? I mean, it's just a simple, I'm in an automobile business. If you want to keep your payment, your insurance payment done, go with a large deductible. The only problem is sometimes you never have coverage for that you need for the problem that you're trying to cover. I think what we can do with this is the government can step in, but we need to be, it's about transparency, isn't it? It's always going to be about transparency. Mm-hmm. Just be honest with us. Tell us what you can't cover. Don't give me some laundry list of things that I have to do before I can get into the doctor. I don't need that. I need emergency care right now. This isn't a disease that's going to wait to get an approval. What we have to do is make sure that we make it easier for the approval to take place. And I think we can do that legislatively, but a lot of it is done with insurance policies that have high deductibles in order to be affordable. So a lot of people have an insurance card, but really no coverage.
Last question. Cancer is a heavy topic, and it's affected us all, loved ones, scares. I want to end this on a positive note. What are you looking forward to over the next 5 to 10 years? You know, technological advances have been so prevalent, and that obviously is also in the field of cancer research. Give me your viewpoint of where we're going.
Wow, I'll tell you, I'm an automobile dealer. I'm a Hyundai dealer. And this is our 25th year Hyundai, and Hyundai dealers have raised over $225 million to fight childhood cancer. I think what we're looking for more than anything else is an awareness. And I know that there's nothing more devastating than to hear your child has cancer, your niece, your nephew, your granddaughter, your grandson has cancer. But the people that it affects are the people that it affects. There's other people on the sidelines that, geez, so sorry to hear that, so sorry to hear that. Well, you know, the big thing is we all need to be that grandpa, that grandma, that aunt, that uncle, that mother, that father facing this problem. And if we can do that, and then we can push our legislators in office, we can look at everything that's on the table and say, can we please speed this up? President Trump's right to try was about we have things in place right now. People need the right to try. And a lot of those folks, as you know, were in a terminal situation. So what were they waiting for? If the final answer is it's finality for you, then that's not the answer that we want. And we certainly, if we can't solve this problem in the United States of America, it can't be solved anywhere. And we're willing to share it with the world. Look at what we did with COVID. We found a way to fight COVID, and we shared it with the world. Now we need to find a cure for cancer as much as we can and share it with the world.
At the local level, what are some anecdotes that you think really work in combating childhood cancer?
Yeah, I think when you look at there's different things that take place, and there's different people that are really champions for this. I mentioned earlier, I'm an automobile dealer. I'm a Hyundai dealer. For 25 years, Hyundai Motor America and Hyundai dealers have joined together to fight cancer, to just completely defeat childhood cancer. And what it is a donation for every Hyundai sold. They make a donation to what they call the Hope on Wheels program. This program, for me, it's Pittsburgh Children's Hospital. So when you see this, you go to these events. We have a Hyundai there, but then we also have little pie tins with different colors of paint, blue paint, green paint, red paint, yellow paint. And when they see these children, most of them brought out in wheelchairs, And I'm talking about some of them who haven't even been to kindergarten yet. And you see them take their little hand and they put it in this paint and they put it to the side of this vehicle. And it's about the helping hands. How can we all work together to stamp out this horrible, horrible situation and make sure that nobody ever has to hear that your child has cancer again? When you see these little tiny handprints all over this car, you say, you know what? This is something that if it doesn't touch you, nothing will.
Yeah, that is some powerful stuff right there. Congressman, thanks for sharing.
Thank you. I appreciate it.
My next guest is here to talk about President Biden's vision for ending cancer as we know it. Dr. Danielle Carnival is Deputy Assistant to the President for the Cancer Moonshot and Deputy Director for Health Outcomes in the White House Office of Science and Technology Policy. Thanks for being with us, Danielle.
Thanks so much for having me. It's good to be back.
Well, I know we had you on last year at a Hill Health event, and you talked to my colleague Steve Scully. Great interview. You mentioned in that interview that, yes, research had been affected by COVID-19. So kind of update us. What has happened since then? What recent progress have we seen, and are we making up for that lost time?
Yeah, I think the answer is a resounding yes. Especially this week, the American Society for Clinical Oncology annual meeting is happening. And so we're live getting a lot of the updates on progress that's been made. The systems are back up and running and really robustly delivering on the goals that the president set forward as part of the Cancer Moonshot.
Let's talk about those goals. You have over the next 25 years some large goals. Can you talk about them, and what are the keys to actually hitting them? Do you have intervals where you're kind of assessing, okay, here's where we are at year 5 and year 10?
Yeah, so the President and First Lady reignited the White House Cancer Moonshot really to mobilize a national effort to end cancer as we know it about a year ago in February. And they set big goals. It's about building a world where cancer loses its power. A diagnosis isn't a death sentence. We prevent cancer before it starts. We catch cancer early so people live longer and healthier lives. And patients and families don't have to navigate their cancer journey alone. The goals were to decrease the death rate from cancer by at least 50% over the next 25 years, and to improve the experience of people living with and surviving cancer, their loved ones and family members. So while the kind of end part of that goal, the end timeline for that goal is out into the future, we know that we have to make progress year over year. Actually, we have to make greater than the most progress we've made year over year in order to achieve that goal. So this is not a let's just plan for a few years and we'll be able to meet it. We are in a full sprint, making sure that we're doing everything we can to have new ways to prevent, detect, and treat cancer through the innovation pipeline, but just as much make sure that everyone across the country has access to the tools we already have and those we develop along the way.
What has been, you've been in this position a couple of years, what has been frustrating? Because obviously there's been a war on cancer for a long time, but there has been, there's been more progress in combating other diseases. What have you learned in the last 2 years?
Yeah, I think we shouldn't overlook the fact that we have made a lot of progress in the fight against cancer. For example, the cancer death rate, that measure we're using, decreased by about 25% over the first 2 decades of the century. If you pull in the 90s, it's by about a third. That is amazing progress. But we're going to have to see an acceleration of that improvement. We've seen some of that acceleration happen since 2016, but there's still areas where we know we're not making enough progress. Just to name a couple, in the prevention area, for every tool that the great researchers and clinicians are talking about on the treatment side, we can do way more in improving outcomes from cancer or even preventing people from getting cancer in the first place through a focus on smoking cessation and nutrition and lifestyle, and not put it on the individual, but make sure as a society we're really supporting these lifestyles that are prevention minded in general and specifically cancer prevention. Early detection is another huge area where we can make progress. We lost a lot of ground during the early days of the COVID-19 pandemic, where we had millions of missed screenings. We are starting to get those back, but we need to really accelerate the access and ability for people to get recommended cancer screenings, because we know if we can't catch that cancer early, the outcomes are much likely to be better.
The president has said that everyone needs to be involved in this massive endeavor. Now, post-COVID, can you talk a little bit about that? Whether that's stakeholders, whether that's patients, and obviously the White House has organized this massive effort across government. I want to ask a couple questions about that later. But, how can people get involved? How can they help the White House? Because obviously we live in polarizing times. Cancer affects every family. I know that led to obviously the tragic death of Beau Biden. What can people do that are watching this right now?
Yeah, I mean, I'll start where your question ended, in that, yes, the president and the first lady, this is personal for them because of their experiences, Beau and other family members. But it's a presidential priority and a White House initiative because it's personal for nearly every American. This is an issue that crosses lines, and we've seen really robust bipartisan support for research and access throughout for decades, and we're hoping to really build on that. But for individuals, there's a couple things. One, like I said, we can do a lot on prevention and early detection. And while we as a government should make sure that every barrier could possibly be removed is removed, affordability and access and time off and making sure people have travel or that we're bringing early detection to them, that's on us. But we need people to meet us part way and to make sure that they're not delaying and that they're taking care of their health early, because it could have such a great impact on their ability to prevent or to survive a cancer. And then we've benefited from a lot of partnerships, additional partnerships from the private sector, academic, nonprofit, who have been inspired and really lined up behind President Biden's vision for this cancer moonshot. And we've been able to use the cancer moonshot as a platform to highlight really great work, because while the federal government can do a lot, that last mile and that access and understanding of communities and really reaching people and driving innovation to as many Americans as possible is really a whole of society effort. And so folks can continue to share their stories, continue to share their ideas, their new actions and collaborations through whitehouse.gov/cancermoonshot.
As far as equity and access, how is the White House and federal agencies ensuring that the people getting the treatment, it's done in a fair way and it's accessible to the most vulnerable populations?
Yeah, I mean, we want to make sure that's true for the entire pipeline, from preventative care and early detection all the way through treatment and survivorship. And so we've announced new initiatives. The president from the beginning of the administration and even prior has worked really hard to ensure healthcare coverage is reaching as many Americans as possible because of the Affordable Care Act. Preventative care is covered, and early detection is part of that. So we really are trying to bring the system to as many Americans as possible. For example, there was a new program from HHS that partnered federally qualified health centers that often serve low-income and medically underserved people across this country to National Cancer Institute comprehensive cancer centers, some of the best of care in the country. And they're going out and they're making sure people are getting cancer screening early, but there's a navigator, someone to walk with them if something is found so that they get to diagnosis, they get to treatment. We have the pipeline really connected. It's just one example. I'd say the Department of Veterans Affairs and the Department of Defense, since they run health systems, have been a huge part of what we're doing and making sure that everything is reaching their communities across the country.
How much of the Cancer Cures Act, which the president, now president, had a lot to do with, how is that implementation going?
Yeah, I think we're about 7 years out, and I think it's made a huge impact. For example, and just to remind folks, the Cures Act was signed by President Obama in December of 2016, really at the end of the administration. But it was a hugely bipartisan act that brought additional funding, $1.8 billion for the Cancer Moonshot at the NCI, the National Cancer Institute. It created an oncology center of excellence at the FDA, which was meant to streamline and offer a place where both researchers and companies and patients can get direct access to information about what's coming up through the regulatory pipeline and what trials might be available. So that's made a huge difference. And then the other part that impacts beyond cancer, but has had a huge impact on the advances we've seen in cancer is people getting access to their health information, decreasing those barriers for people to be able to access their own information and then seek that second opinion or that trial, really be their own advocate in finding the care they need.
Regarding, there was as you know, a deal in Congress with the debt ceiling. Are you confident there was a bipartisan compromise? It's gotten through. Are you confident that still the funding is going to be there? Because there have been some conditions which were attached on spending. Are you confident that the cancer research is going to get the money it needs?
Well, listen, like I said, there's been really robust support for bipartisan support for cancer research in the past. We don't think that's going anywhere. The deal that was reached enabled us to move forward, enabled us to maintain priorities. And for this president, cancer and this Cancer Moonshot is a priority.
Danielle, thanks for joining us. Really appreciate it. You've got a very important job. We wish you the best of luck.
Thank you so much.
And now it's time for the sponsor perspective portion of our program. The Hill's General Manager and Senior Vice President, Joe Ruffalo, sat down earlier with Dr. Harlan Levine, the President of Health Innovation and Policy at City of Hope. Have a listen.
Harlan, thank you for joining us today. Let's dive right into the topic, cancer care access and equity, breaking barriers to innovation. Why is talking about this issue so important?
Well, hi, Joe. Thanks for having me. We live in a groundbreaking era of innovation in cancer care, but unfortunately, not all patients are benefiting equally. Outcomes for survival vary dramatically. They vary by zip code, and they vary by distance from National Cancer Institute comprehensive cancer centers. These are our leading cancer centers for care and for research. And unfortunately, there's a growing chasm between the innovation that's taking place at these specialty cancer centers and the people who need it most. At City of Hope, a national cancer research and treatment system, we're committed to bridging that gap and expanding optimal care to more patients, more families, and more communities.
Could you tell us more about these gaps and where we're seeing them? What are the barriers separating patients in these breakthroughs? And why do they even exist?
Yeah, with the emergence of precision medicine, everything's improving. Treatments are improving with immune treatments and CAR T cells. There's better diagnostics with genomics. There's better surgical techniques with robotic surgery. And together, these have helped to reduce the mortality rates by 33% since 1991. But these breakthroughs are not equitably distributed, and too many people are being left behind. Take, for example, in California, one study showed that fewer than half the cancer patients were receiving care consistent with national standards. And this is worse for people who are coming from underserved communities. For example, African American men die at twice the rate from prostate cancer, and women, African American women, 40% the rate from breast cancer than their white counterparts. And think of this, if you could take away all the social determinant of health disparities, 1/3 of the deaths could be prevented in young adults between the ages of 25 and 74. So we know that social determinants of health and genetics are drivers of this disparity. But I am concerned that it's the complexity of our health system that is exacerbating these problems. And even some of the things that we do under the banner of value-based care are making things worse.
I've heard the term value-based care thrown around a lot. You just recently wrote a piece for The Hill about this. Can you tell us a little bit more about what this means and how it impacts access to optimal cancer care?
Yes, value-based care should be care that's been designed to achieve the optimal outcome. But unfortunately, every stakeholder has their own definition of optimal outcome. And too often we focus on cost containment, which is the payer perspective. We need to also include the patient perspective. And cancer patients are telling us what they value. They value survival, they value access to expertise, they want a respectful experience, and they want to return to normalcy with as much function as possible. But in the area of access to expertise and survival, let's look at Medicare Advantage plans. These are plans that have more than half the Medicare beneficiaries, and that's about 30 million Americans. Most Medicare Advantage plans use what we call narrow networks to contain cost. And narrow networks mean that you have, as a patient, you have to see providers and hospitals that are in that network. Those narrow networks do work for things like diabetes and back pain and heart disease, where there's an abundance of care, but they do not work for cancer care.
And why is that?
Well, frankly, cancer care is different. The field is no longer just one specialty, but really functions more as multiple subspecialties. With precision medicine, cancer is now understood to be 100 different diseases, each one defined by a DNA blueprint or specific genetic makeup. And there's new information and new treatment emerging all of the time for all of these cancers. It's really humanly impossible, if you're not a subspecialist, to keep up with all that emerging information. So when we narrow a network that is already stressed to keep up with all the new information, we're actually making the problem worse and outcomes decline. And we know from the data that Medicare beneficiaries are far less likely to access one of these specialty centers or even a center that's accredited by the Commission on Cancer. And this is actually true in commercial plans as well. So if you think about it, this lack of access really hurts the outcomes. Take, for example, Medicare Advantage. Patients who have cancer surgery on their stomach or their liver are 50% more likely to die in the first 30 days. And if you have surgery on your pancreas, you're 100% more likely to die in the first 30 days. And also, these narrow networks don't have oncologists that are experienced in and confident using precision medicine, or they're not trained to deliver some of the newer therapies like CAR T-cell therapy. And they certainly don't have the infrastructure to conduct early phase clinical trials. So patients are less likely to receive these approved therapies, and they're far less likely to enroll in research trials that may offer the best treatment.
That's interesting. Can you tell us more about this research and the impact that narrow networks have on it?
Well, so because of precision medicine and targeted therapy, research trials are no longer shots in the dark and oftentimes include the best chance for cure, particularly for people with advanced cancers. But if people can't access these centers, then they're not getting on the trials, they're not getting a chance to live, and then we as a society aren't innovating and finding the next generation of cures and solutions for patients. Take, for example, lung cancer. 10 years ago, if you had metastatic lung cancer, you averaged 6 to 8 months to live without a clinical trial. But if you were on the right clinical trial, you would be living on average 60 to 80 months, and you could still be alive today. And without having done those trials 10 years ago, we wouldn't have all the life-extending treatments that we have today for lung cancer. And because we know minorities are in more narrow networks, again, they're disadvantaged. We know that African Americans represent 15% of cancer cases in the United States, but they only make up 4 to 6% of patients in clinical trials. So again, narrow networks for cancer are perpetuating unacceptable disparities, and by blocking people from getting into trials, they're slowing the progress in finding cures for the future.
So what are some examples of policy solutions that we could offer that would eliminate these barriers to innovation and improve cancer care and access and equity?
Well, we know that changing policy is really hard. But at City of Hope, we believe it's our obligation to be part of the solution. And we think we have a model for future policy reform. In California, 2 years ago, we started with the California Patient Bill of Rights resolution. It was the first of its kind, and it laid out the rights of every cancer patient upon diagnosis. And then last year, we took on the California Medicaid program. We did that because in many cancer types, patients with Medicaid actually had worse outcomes from people that had no insurance at all. So we helped to enact the California Cancer Care Equity Act, in which we ensured that patients with complex cancer have the right to go to an academic center if their narrow network doesn't have the appropriate level of care to take care of their advanced cancer. And now this year, on a federal level, we're looking to redefine network adequacy. We want to modernize our definition to keep up with all the innovation that's happening in oncology. And to do all of this, to drive all of these changes, City of Hope launched what we call as the Cancer Care is Different Coalition, with multiple stakeholders across the industry to raise awareness that cancer truly is different.
Is there anything else you'd like to share with us today?
Well, I'd just like to say that health plans of today are really ill-designed to keep up with the innovation in cancer, and they lead to disparities because of the barriers that they create. So if there's two takeaways I'd like our audience to have, one is that cancer care is different, and two, we really need to define value thoughtfully, particularly when we talk about value-based care. Truly transforming cancer care requires stakeholders to work together and be open to a new approach and new alignments. One place to start is simply to think about how can community oncologists work better in partnership with academic medical centers. City of Hope actually started a company called Access Hope, where subspecialists and experts from NCI centers work together specifically to support medical oncology take care of their patients in the communities. But if we step back and look at this holistically, I would assert that it makes no sense to focus on cost containment on a system that is already leaving too many people behind. And perhaps we need to change our priorities and first start with solving health equity issues and access issues. And once we have those solved, then we can begin to focus on affordability and value, and this time define value with the patient in the center.
Harlan, thank you so much for your time today, and I'd also like to thank City of Hope for sponsoring today's program.
You're very welcome.
Thank you.
Karen Knutson is the Chief Executive Officer of the American Cancer Society and its advocacy affiliate, the American Cancer Society Cancer Action Network. For more than 100 years, the American Cancer Society has been improving the lives of people with cancer and their families through advocacy, research, and patient support. Welcome, Karen.
Thank you. Pleasure to be here.
Let's start with some good news. Your group, the American Cancer Society, has published a study revealing that the mortality rates for most cancers have decreased. Can you describe that study and your takeaways from it?
That's right. Every year we look at cancer incidence, mortality, and trends in a large research study that we conduct across the country. And what we've seen since 1991, which was the high watermark for cancer mortality rates in this country, is a 33% decline overall in the 200 different diseases that we call cancer.
And there are a couple that haven't had the progress of others. What was the issue there, and where do you see those type of cancers being treated going forward?
Yeah, so we actually look at this quite in depth for these 200 different diseases, and we know that a significant portion of that mortality decline came from prevention, screening, and early detection. So it's notable that we've made meaningful gains in many of the screenable cancers, as well as those for which we have early detection strategies. Now, there are other cancers for which we have significant concern because the trends are what we would call going the wrong way. Things like the early onset colorectal cancer, which we see on the rise. Things like advanced prostate cancer, 5% year over year shift in diagnosis to more advanced disease. or for cancers for which we really have no early detection mechanism yet, like pancreatic cancer. So we take each one of these individually, set priorities, and then develop strategies using research, advocacy, and patient support to address them.
Karen, what have you found as far as across the country in underserved populations, rural, urban? What trends do you see?
Yeah. So unfortunately, what we see are sustainable trends that have occurred across the nation with regard to access to breakthroughs. So, we're in this incredible period of innovation in oncology. We just came back from 1 week at ASCO, the American Society of Clinical Oncology meeting, where we heard about many, many new strategies for treatment therapy and early detection. But it's quite clear that only a subset of the population is actually reaching those breakthroughs. So there are many things that we need to do together to address this. Some of these are legislative or policy related in nature, and others are associated with physically getting patients to access to more advanced care. Things like transportation, patient navigation, housing near cancer centers make major differences in actually getting someone access to these breakthroughs. So it's a whole conversation in itself, but what I would say is we are in the game at the American Cancer Society every day trying to close those gaps.
You mentioned legislation. What would you like to see Congress and or the administration do, whether that's authorizing legislation or appropriations legislation?
So much to do. So let's just talk about a couple quick ones. First has to be the breakthrough engine needs to keep going, and that is the funding for the NIH and the NCI. For FY24, we're seeking $51 billion for the NIH and 9.988, a very specific number, for the NCI. That we are at this pace of discovery that needs to sustain. But then how do we ensure that everyone gets access to these breakthroughs? Well, the most advanced form of cancer care comes in the form of clinical trials, and too few of those in the United States have access to clinical trials. So we're very highly supportive of the Diverse Trials Act. This makes it easier for all patients to participate in cancer clinical trials, removes barriers for underrepresented individuals, allows greater flexibility for things like telehealth, which we know can help close those gaps, and limits the tax implications that participants may face. It's notable that patients cite cost as a top reason for declining participation in clinical trials, making those the individuals making less than $50,000 a year are 30% less likely to enroll.
When you talk to patients across the country, what do you hear that maybe Washington politicians should also hear?
Yeah, I think what they hear is that they understand that there are these breakthroughs that are coming and that are here, but they don't know how to access them. So enhancing access to screening, to clinical trials, as we just talked about, but also to support for patients of how it is that they can navigate their journey. Even for someone in healthcare, navigating a cancer journey is incredibly difficult. Cancer patients are frequent flyers. They're back and forth to many different types of care teams at a cancer center. And even just making the appointments or understanding the sequence of events can actually be a barrier to surviving cancer and a barrier to a positive outcome. So what we hear loud and clear is a desire for patient navigation to be a reimbursable component of the care team so that everyone has more of an opportunity to detect and survive cancer.
President Biden's Cancer Moonshot initiative, where do you think it is? Obviously, COVID set it back a little bit on research, but where do you think it is, and do you think it can be successful? It got some bold goals over the next 20 plus years.
It has bold goals, but I am highly optimistic that we will get there, and we at the American Cancer Society are leaning in hard to participate in every element of that framework. Now, what I love about this iteration of the Moonshot Reignited is the emphasis on prevention, screening, and early detection. We will not be able to continue to reduce the mortality rate for cancer unless we intervene early. Early detection for cancers are associated with an improved outcome for almost every cancer type, and certainly with reduced cost of care for everyone involved. So this emphasis on escalating access to early detection and prevention, I think, will be key for the Moonshot to succeed.
When you're talking about early detection, and obviously that is the key. Obviously, there were some routine appointments that people skipped during the pandemic. What does the data show? Are people going back to the doctor and making sure that if anything needs to be detected, it is early?
Yeah, unfortunately, we have not seen the recovery that we need to see. I should say that even prior to COVID, screening rates for the screenable cancers in the US were not where they needed to be, and COVID exacerbated the problem. If we look at 2020 alone, we see that more than 9 million Americans missed their screening, and we have deep concern that those Americans are sitting now with a cancer that's not yet been detected and will present with more aggressive disease, again, more difficult to treat. So there are things that we really can and need to do. And when we look at screenable cancers like prostate cancer, where we're seeing this increase in advanced disease stage diagnosis, we look at potential solutions that can come through advocacy and through legislative activity, like the PSA Screening for Him Act. This act removes out-of-pocket costs, which are real barriers for screening, for men at high risk of prostate cancer. This is important because almost 1/3 of cancers diagnosed for men in this country this year will be prostate cancer, and it is the second leading cause of cancer death for men in the United States. So it's the case that reintroduction of this bill into Congress has been, I think, a win, and it will soon, as we believe, be reintroduced into the Senate. And so these types of activities truly can save millions of lives.
Where are we as far as certainly the pandemic raised some major policy concerns, and Congress responded with a lot of money and also passing the CHIPS bill because we have become so reliant on other countries on treatments and drugs. What did the pandemic mean for cancer patients, and is that getting better?
Yeah, well, I have a different lens on this because at the time I was actually leading oncology for a large health system, 18 hospitals across 2 states. So I felt it firsthand. Cancer care did not stop during the pandemic. Patients still were diagnosed with cancer and needed to be treated and needed to be on clinical trials. So thankfully, all of that continued. But what didn't happen was that front end, the screening. And so those that were already diagnosed with cancer largely were able to get treatment, but those who should have gone into screening, these healthy asymptomatic individuals were concerned, are still sitting with potential cancer that needs to be addressed. So we've not seen that bounce back in screening that we need. Now, I would say there was a silver lining in the pandemic for cancer, which was the incorporation of telehealth into the cancer care continuum for someone who's had their scan and needs to talk to their oncologist but doesn't need to actually have a physical exam. Telehealth became a wonderful opportunity to extend that communication between the cancer patient, their family, and the provider. That continues today. I do think that there are ways that we can continue to escalate that and bring cancer care into closer to home where possible, so that we can help close some additional disparities that exist due to geography and proximity to cancer centers. But there are opportunities for that to be eased through considering ways to facilitate that state to state so that it's easier for patients and providers to communicate with each other on something as important as cancer.
Last question, it's a broad one, but what are you looking at for technology next 5-10 years? Where are we going to be in the next decade?
As I said, we're in this incredible, unprecedented period of innovation for oncology. We've had surgical radiation and medical oncology, so, classic chemotherapy, now be augmented with a whole new brand of therapy, immunotherapy. We will see additional innovation there and immunotherapy functional on multiple cancer types. But I also know that we'll see innovation in different parts of the cancer continuum. Innovation in early detection, even early detection at home, including but not limited to blood draws to detect cancer cells that are circulating in the serum, or cancer in your blood, or cancer DNA, that can give someone the earliest possible indication that they may have a clinically meaningful cancer. So we're watching that and looking at that. But we will also see innovation in imaging, including the incorporation of artificial intelligence or generative AI to help rapidly assess images for cancer development or cancer progression. So I think we will see innovation across that cancer continuum, everything from prevention to early detection to understanding how to adequately put patients into different types of personalized medicine therapy strategies, and as well as enhancement of quality of life. All across the cancer continuum, we are seeing innovation. That's why it's so important for us to keep cancer research going.
Absolutely. Karen Knutson, thank you so much for joining us.
My pleasure. Thank you so much for asking me.
That was a very interesting interview, and now we move on to the panel. It's time to discuss geographic and equity roadblocks to cancer care with our panel of experts. I'm joined here in studio with Isabel Duran. She's president and executive director of the Latino Cancer Institute and member of the National Cancer Advisory Board. And we are joined virtually by Dr. Daniel Derman, Senior Vice President of Administration and the Chief Innovation Executive at Northwestern Memorial Hospital in Chicago. And joining us in just a minute will be Dr. Lisa Newman, Chief of the Section of Breast Surgery at Weill Cornell Medicine and New York Presbyterian Hospital in New York City. Welcome to you all. I do want to start, Isabel, with you. You have a personal story. You've invested a lot of your career in educating the Latino community. Also, you were diagnosed, I believe, 20 years ago. Can you tell us about your personal story and where in that 20 years cancer research and the search for a cure has come?
Good to be here with you. But, you know, it's really interesting for me because when I was diagnosed 23 years ago, it was because I had regular screenings, I had a doctor, I could speak the language, I was educated and well aware and able to read any kind of medical journals I needed to in order to understand. So that was not the problem. But I remember when the doctor called me, he said he felt he needed to call me right away. I had Hodgkin's lymphoma. He said, I can't believe this. This is cancer. And my first reaction sitting there was, okay, God, this isn't about dying. What's the point? And the second one I had was, I wonder if I should do a story, because I was a television journalist for 43 years, and my immediate instinct was to turn the camera on myself and share with the public what was even then called the Big C. So when you think about 23 years later, where I've developed 2 local nonprofits and then created the Latino Cancer Institute to work at the national level and focus a lot on policy, I think about the fact that we actually went to Stanford back in 2000, and we were asking about advanced cancer research, and they were looking at immunotherapy. And now here we are all of these years later, and immunotherapy is in use in many comprehensive cancer centers. What has not changed to a great extent in all of these years is that the disparities still exist. Who's getting access to that? Who can afford it? Who is getting directed into those cancer centers? I think one of the great things I heard from the doctor from City of Hope is in California, they have signed a bill that we supported that would allow Medicaid patients to go to comprehensive cancer centers and get these advanced therapies. And so there is this like one step forward, but too many steps back. And I think it's really critical that the community be engaged at all levels in order for us to get to the place that Karen Knutson was talking about, prevention and early detection. We have to bring the community into it, we have to educate them, and we have to provide them navigation into these systems so they can get that early detection and they won't become, one, a cancer burden to their family, financial toxicity, which becomes that big problem, and they won't be a late-stage diagnosis that we have to perhaps with end-of-life care, which is multiple and costly.
Sure.
I mean, it's a really horrible place to be. So we're really trying to change that trajectory.
Dan, you want to bring you in here. Where are we as far as gaps in cancer care right now, and what can Washington policymakers and maybe state policymakers, Isabel mentioned the California legislation, what can Washington and other policymakers do about it to actually improve quality of care over the next decade?
Yeah, unfortunately, we still have a significant set of gaps. And let me give you just some numbers or some facts around that. So let's look at patients that are receiving National Comprehensive Cancer Network care. Less than 50% of patients over a period of time actually have access to that. What kind of variations are there in outcomes? We know that there are significant outcomes in the gap between the mortality, the death rate, in those that are in community centers versus highly specialized cancers. There's about a 19 to 20%. These are people that are getting treated. Forget about those that don't have access to care. There's about a 20% gap between these different centers. Many people are talking about genomics and precision medicine. These things are rapidly advancing, and the access to them are not keeping up with the technologies are available. I'll allude to that in a minute when we get back to what Washington can do about that. As an example, we know that 10% of all the cancers are driven by inherited genetic mutations. But across America, only 27% of that 10%. So of that 10%, only 1 in 4 are getting checked for genetic testing in that regard. So we know that that's just an example of those that are being treated are in the system. If we look at the kind of things that we can look to both state legislatures or Washington that could help us out, I think there are many. The first would be on insurance regulation and making sure that people have access to the most timely medicines and therapies and diagnostics, and that those are covered by the various insurance as well. Also, whether it's treatments and getting them covered as well. These are areas that we lag behind, and things are moving so quickly that we don't actually have the mechanisms by which to make sure that the treatments, as they come online, give access to folks. Now, the program we're involved with City of Hope and others, called Access Hope, is making some dent, at least in the insured population, by making sure that those people everywhere in the country, by their employers, will have access to the best treatment and care possible. And as far as the access to Medicaid, in Illinois at least, we also, at least at Northwestern, open ourselves up to all of our patients, whether they have Medicaid, Medicare, insurance, or otherwise.
And so just as a quick follow-up, what do you think that out of all of that, and some stuff has moved through Congress, what do you think the Washington policymakers can learn from all of that?
Well, I think probably the most important thing, given the speed, how the field is changing, both in diagnostics to make the diagnosis as well as therapies, it's figuring out and making sure that we have access and our patients have access to this cutting edge diagnostics and treatment as soon as possible.
Mm-hmm. I want to bring in Dr. Lisa Newman, Chief of the Section of Breast Surgery at Weill Cornell Medicine and New York Presbyterian Hospital in my hometown of New York City. Lisa, we've been talking about early detection, and you served as chair of the steering committee for the American Association for Cancer Research Cancer Disparity Progress Report. Can you share kind of what were the key takeaways from that report?
Thank you. Yeah, this Disparities Progress Report was a wonderful opportunity for the AACR to put together kind of a blueprint for understanding the various factors that contribute to cancer disparities. You heard about several of them from Dr. Derman, and I wanted to also build upon his comment about inadequate genetic testing being performed in our patients. Unfortunately, that genetic testing is disproportionately low in communities of color, which means that we are hampered in understanding the types of genetic factors that contribute to cancer incidence and outcome in many of our population subsets, such as African Americans and Hispanic Latino Americans. And this has important ramifications in terms of treatment. The technologies of precision medicine are such that now we can target specific markers on cancers that are related to our genetics. And so if we do not understand some of these genetic markers in communities of color, those communities are at a disadvantage in terms of being able to take advantage of these precision medicine technologies. So in the AACR Disparities Progress Report, we discuss some of those inadequate aspects of cancer evaluation in communities of color and medically underserved populations. We also have an opportunity to talk about how critical it is to expand the overall research portfolio involving diverse patient populations, because cancer at its core is a genetic aberration. And unless you study cancers broadly in communities of all backgrounds, then you're never going to really comprehensively understand the etiology, the cause of cancer, because you're just getting a snapshot of those cancer genetics in small populations. So having a broad picture of cancer genetics in diverse populations will be extremely important so that we can generalize what we learned from clinical trials. Unfortunately, at this point in time, communities of color are disproportionately underrepresented in cancer research. We also talk about how important it is to diversify the oncology research workforce and to diversify the oncology care providing workforce. If we have an oncology research and care delivery workforce that better reflects our patient population, that means that our research is going to be smarter. We will be tapping into the creativity and the brilliance of young minds that unfortunately have been systematically excluded from healthcare professions in the past. And we will deliver healthcare, cancer care better, because that care will be delivered by communities that have perspectives and experiences, life experiences that are more consistent with our patient population.
Isabel, I want to go to you. We were talking before we got started about cost. You know, you have it's inside baseball, but the FDA approves treatments. But that's just one step of the government process, and it also affects the private market, because then if some type of treatment or device is approved by FDA, then it's got to go to CMS for actual payment. And we've seen this. So I want to break down the cost issue, because it's so important. You can't have accessibility if you can't afford treatment. What has been your experience with that?
Well, having worked in the low-income community, cost is always a barrier.
Sure.
And in fact, they create, to my experience, they create the barrier themselves. They don't go because they're afraid of the cost. So already there's a moving towards late detection. To Dr. Newman's point about access to genetic and genomic testing, what we have seen in some of the work we have done with federally qualified clinics, that there are issues about protocols, when to test, who to test, who's going to pay for it, and so this creates a real backup for some of the women we're trying to help. When we identified 150 women and 30 of them with family cancer history and some tools that we use to test the degree, we determined that all 30 of those women needed to go in for testing. It took us 1 year to get the first woman in to see the one clinician who could look at her case and determine whether she should get genetically tested or not.
It took a year.
It took a year. And now we've seen a little, because we helped them create the flow chart.
Right.
So we're now looking at this once again from a second level of research, because we, the community, can't go and say, you guys are doing this wrong, it's not working for us, we got to do it differently. We do have to show evidence base. We do then have to be approved in terms of changing policies, rules, regulations. But most of all, I think you brought it up much earlier, the payment regulators, I heard one of the guests say so, they have to be brought to heel, excuse the expression, because the charges in medicine, the cost of medicine is way over. It's
Sure.
it's too costly for anybody. So we have to get that under control. But we're working to show the problem, and that despite standards of care, many low-income communities and communities who are unaware of the kinds of testing they should be getting, the lack of knowledge about family history, all of these early steps towards intervention, because of all of those gaps in services, we're working to try to bring those together much more quickly. Going to the Moonshot,
Sure.
the desire for the Moonshot to decrease mortality, trying to change. I love Dr. Newman about the changing the pipeline, improving that. We want to expand that pipeline to community health workers. That becomes the bridge to bring folk in early, to educate them, navigate them into systems, turn them over to these now professionals to do the work, and smooth the way for them to get their work done. It's a continuum that needs to be addressed. And I think that with President Biden during the Cures Act calling for the development of a community healthcare workforce, and Governor Newsom putting $10 million into the beginning of the development of a community healthcare workforce, is a recognition we don't have enough people in the pipeline, and that will be slow all the time. And we don't have oncologists of color in the pipeline, and we don't have Spanish-speaking and other folks of other languages in the pipeline fast enough to do this work. So why can't we start on this end and do more prevention, while we're trying to up the pipeline, up the specialties, up the opportunity to get to these very advanced care? Let's work here in the community and start there and make them our partners and equally invest in them.
We have an audience question, and I'm going to direct this to Daniel. This comes from Ian Terrell, Health Research Librarian, Kaiser Permanente Center for Health Research Panel. And the question is, the ability to fight cancer seems restrained by a shrinking number of qualified caregivers. How are we addressing the need for more nurses, doctors, and specialists? Dr. Derman, can you answer that?
Yeah, well, there's a longer-term answer that is the pipeline, but I'll give you a short-term answer that we're working on, which is thinking about and using innovation to extend the scope of every provider that we have. And I think I'll use an example that is just meant to be directionally. Don't take this to the bank as the right numbers, but let's just say on nursing workforce. If a typical inpatient unit has 10 nurses who staff that unit, we're going to figure out over the next 5 years, because we don't literally have 10 nurses to do that. We're going to figure out where the future is going to look something like, of the 10, 4 will be traditional nurses that will staff the unit as they've always staffed them. 3 will be not replaced, because it's not a matter of replacing, but we don't have enough. 3 of the traditional bodies will be served by technology. And for instance, there are remote nursing projects going on now, and there are other uses of technology that are going to solve 3 of those 10 nurses on a shift. And the other 3 that typically were on a shift will probably be some form of just-in-time staffing that will come in, and I don't want to call it a gig economy, but will come in on an as-needed basis. This is just an example in today's terms of different things that we can do. Use of AI technology. If we look at a radiologist and someone who reads, we, for instance, have a program going on at Northwestern where we are augmenting our radiologists in the use of reading of mammograms. And the pilot we have shows that every radiologist is 30% more productive with adding on and using the AI technology. So there's an example of a classic example that's been used elsewhere typically than in healthcare, to use technology to augment the workforce. So we're going to have to implement these really in super speed time to try to accommodate this, because everyone in the pandemic thought that there was a absence of the workforce due to the pandemic. What we've come to realize is that this was an impending crisis that was coming upon us, only exacerbated by the pandemic. And as it recedes, those issues are still there. So my short answer is we're going to implement in the short term technology to take every provider and in general, as a goal, try to make the system 30% more productive by the use of technology.
Lisa Newman, can you talk about breast cancer survival rates? Have they improved? What can we learn from that? Everyone knows someone who's had breast cancer.
Yeah. We are making huge strides in terms of improving outcomes from breast cancer for all patients overall compared to the past. And we deliver breast cancer care better. One of the buzz terms in the oncology community is the concept of de-escalating breast cancer care, which means that we are targeting specific types of breast cancer more appropriately so that the treatment is more effective, but also with fewer side effects. So that's been a wonderful advance in the management of breast cancer, leading to improvements in outcome. But unfortunately, as has been iterated in this forum, not all population subsets have been able to avail themselves of those advances equitably. And so we do still see 40% higher mortality rates from breast cancer in African American women compared to white American women. Part of this is related to the fact that there are differences in the tumor biology of cancers that are more likely to afflict African American women. Black women are more likely to get the biologically aggressive triple negative breast cancers. And this is another area where we need much more research to understand the genetic causes of triple negative breast cancer so that we can help to minimize these breast cancer disparities between Black women and white women. But the treatments are better, they're more effective, and yes, we are seeing better outcomes from breast cancer. And I'm happy to have witnessed recently that the United States Preventive Services Task Force is now advocating in favor of average risk American women initiating screening mammography at age 40 compared to their prior recommendation of waiting until age 50. And I have no doubt that this younger age recommendation for mammography is going to save thousands and thousands of lives across the country for women of all racial ethnic backgrounds.
We've run out of time. Very informative panel and a hopeful one. I want to thank the panelists, Dr. Daniel Derman of Northwestern Memorial Hospital, Dr. Lisa Newman of Weill Cornell Medicine and New York Presbyterian Hospital, and Isabel Duran of the Latino Cancer Institute for being with us today. Thank you. Congressman Brian Higgins from New York is a co-chair of the Cancer Caucus. He joins me now to talk about what Congress can do to help in the fight against cancer. Congressman, welcome.
Happy to be with you today. Thanks for having me.
Can you tell us a little bit, Congressman, about the caucus, how often you meet? I know it's bipartisan, and kind of what are your goals in this Congress?
Well, we meet on a fairly regular basis, the objective of which to make an argument to our colleagues writ large, the importance of funding cancer research, the National Institutes of Health, and the National Cancer Institute. More money means more research means more life-saving therapies, and cancer is a bipartisan issue. It affects all Americans, and everybody has been touched by cancer, not only individually, but indirectly as well through family members and friends, etc.
As far as legislation, you've introduced a lung cancer screening bill. You also have a bipartisan cancer drug parity bill that has a number of both Democrats and Republicans on it. Are these two pieces of legislation perhaps can move maybe as part of a larger vehicle?
I do think they can. As you know, cancer and cancer research funding often competes with other issues as well. So it's incumbent upon the members of Congress in a bipartisan way to instill an appreciation for the importance of funding these initiatives. So we keep trying, we introduce each session, and our number of co-sponsors usually increase. So it's like anything else, it's reaching frequency, and we continue to persist toward the goal of fully funding cancer research.
And I saw that in the past, Senator Tina Smith has offered a companion bill. So you're hopeful it could get through the House and Senate because it is bipartisan, but it's still hard to pass anything nowadays.
That's right. Anything that becomes law needs same as legislation in both the House and the Senate to pass, and then it goes on to the president for signature. So it is an arduous process, but having a co-sponsor in the Senate is obviously very helpful to our efforts.
Recently, as you know, Congressman, the parties came together. We're in divided government. I was skeptical that a deal was going to get done, at least before we hit the so-called X date and the debt limit ceiling showdown did evaporate, and the House and Senate passed a bill really with big bipartisan majorities. Are you confident that there's going to be the funding that's necessary, for whether that's NIH or other government agencies, for cancer research?
Well, that was a problem. As you know, there were certain things that my colleagues on the other side wanted to protect, like Social Security, Medicare, and military spending. That put everything else on the table. And had they succeeded in their nearly $5 trillion in cuts, there would have been cuts to the National Institutes of Health and the National Cancer Institute. The good thing is there was a compromise that was negotiated, and those things will not be as adversely impacted as they otherwise would have been.
How do you rate the White House Cancer Moonshot initiative? We've talked to some people, and obviously COVID did set back some type of cancer research, but it seems like the engines are running again. Do you think that the White House this is actually going to lead to some major technological improvements so that patients can improve their quality of life?
Well, like anything else, I mean, goals are very, very important. And reducing cancer by 50% in 25 years is a good goal that we all should be pursuing. The question is, are there resources to help you achieve that? Stating a goal doesn't get you there. Working toward the goal with resource does. So I think that the administration has done its job by laying out a vision for what it is they would like to be able to see relative to cutting cancer, the incidences of cancer. But the question is, are the resources going to be there? And that's more of an annualized process that members of Congress participate in.
As far as what you're hearing from constituents, and obviously everyone's been touched by cancer. We all know somebody who either has the horrible disease or has succumbed to it. What do you hear on the ground back in your New York district that you bring to Washington to hopefully get through the morass of acronyms and that kind of stuff to actually get to solutions?
Well, I think it's understanding, the pathology of cancer and how it works. Less than 10% of cancer deaths are attributed to the original tumor. So it's when cancer metastasizes, when it grows, when it moves to an organ that you can't live without, then it becomes lethal. So early detection is important. The outlook for someone diagnosed with a stage 1 or 2 breast cancer diagnosis versus a 3 or 4 is profoundly different. So early detection is very important. The other issue that's very important is lifestyles and educating people how devastating smoking can be. We could reduce 30% of all cancer deaths by the elimination of cigarettes and smoking, 80% of lung cancers. So that's a lifestyle, and that's why it's important to have good information out there to the general public about how deadly, literally, smoking can be as it relates to cancer. So it's those kinds of issues, and general screening to detect cancer early greatly enhances the survival rate of those who are diagnosed with cancer.
Do you get the sense that because early detection is so important, certainly during COVID, A lot of people, including myself, didn't get our annual checkups. Are people going back to the doctor's office now? Because if they don't, it's going to be hard to detect anything if anything is there.
Well, they are, but it's first of all, before the pandemic, cancer screening was a big problem. And then obviously during the pandemic, it was exacerbated. And now getting people to get back into a mode of getting cancer screening is critically important to survival and to save money as well. We spend over $200 billion a year as a country in cancer care. 1.9 cases of cancer will be diagnosed this year. 600,000 people will succumb, will die from cancer. So we can certainly do better with those numbers. But it's all about education. It's all about resources. It's all about encouraging people to take the initiative themselves so that they get the screening that's necessary to, if they have cancer, to get an early diagnosis, early stage, which, as I said, will greatly enhance the survival rate of those patients.
We do have an audience question for you, if we can put it up on the screen. And this is from John Albaugh, Director of Payer Analytics at McKesson. What is the biggest challenge for Congress to help CMS control costs? CMS obviously being the Centers for Medicare and Medicaid Services, that they decide reimbursement. What's your take on that question?
Well, the federal government spends about $1.7 trillion a year on healthcare in terms of Medicare, Medicaid, Veterans Administration, and tax treatment. It's a lot of money, but it's also a lot of leverage. So using our leverage to the greatest extent possible to ensure that we drive up the quality of care and down the cost of care. It's a lot of money, and the federal government, has a good chunk of that as it relates to the total bill nationally. So using that as leverage toward the goal to drive down the cost and up the quality, it's like anything else. Everything in life is about leverage, and I would argue that the federal government doesn't use its leverage as effectively as it could or should.
What about access to healthcare? You mentioned that a lot of these treatments, they can be costly. How can we ensure that underserved communities are getting the fair treatment that other communities that are well-served? How do we deal with that problem?
Yeah, well, I think it's about accountability, and it's about ensuring that people that buy healthcare, which is already very, very expensive, that they get a good quality product, that they have essential services, that they're not denied for pre-existing conditions. As you know, one of the component parts to cancer is heredity, and that is a determining factor of who will get cancer moving forward. Not exclusively, but one of the variables that certainly go into causation. So it's making sure that those people aren't denied coverage, because those are the people that need regular screening. Those are the folks that can benefit mostly from early detection, because, as I said, survival rate increases with earlier stage versus late stage cancer.
The NIH has not had a permanent confirmed director in more than a year. President Biden has nominated Monica Bertagnolli. How important is it to get someone in that position and get her confirmed quickly?
Well, it's important. We're sad that we're losing Monica as director of the National Cancer Institute. But the National Cancer Institute includes the National Institutes of Health. Or the other way around. So Monica will be, obviously, as a cancer doc and a cancer patient now. She will be a great advocate with Congress for increased research funding generally to the National Institutes of Health, but specifically in continuing to be a great advocate for funding for the National Cancer Institute.
Congressman Higgins, thanks so much for joining us today.
Thanks for having me. Appreciate it very much.
And that brings us to the end of our Cancer Care Access and Equity program. A big thank you to our sponsor, City of Hope, and to all of you for watching. For those of you who missed any of the conversations this afternoon, you can catch up on what you missed on demand on our website, thehill.com. I'm Bob Cusack. Have a great rest of your day.